Thank you, everyone. Everybody awake after that wonderful lunch. Hopefully I'll keep you awake here. So I hail from the great state of Texas with Dr. Krazier, and Houston, Texas is my home, but Dubai is in my heart. So let's start. Reversing cardiovascular disease and diabetes. Next slide, please. Oh, I have the clicker, sorry. All right, we want to talk about the endothelium. So the endothelium is that inner lining of the blood vessel. We all know about it, we're cardiology trained and tried and true. We know that we want to tell the patient that the endothelium is the most important part of their body. It's actually a surface area of about 4,000 to 7,000 square meters. We used to say that the skin was the largest organ, right? Skin is only about 2 square meters, so the endothelium wins here. And the endothelium is so important because of inflammation. So every day I'm seeing patients in the office and talking about inflammatory disease, and they say, "Doctor, what do you mean? You mean like an infection or something turning red?" And I said, no, this is the body's response to injury inside of your artery. And this is the most important place that we have to look at, because this is where plaque develops. Plaque develops because of inflammatory cells. Along with these normal red blood cells, we have all this inflammation going on, and that means oxygen-free radicals. And that's causing plaque to form. So this is a nice little cartoon depicting a patient with no symptoms and patient having a heart attack. But they're both having inflammation at the endothelium. It's just that that plaque broke because there was an unstable lesion, unstable things happening at that endothelial lining. So all of you can appreciate, you cardiologists out there, interventionalists like me, who had to go in at 2 a.m. and stent something and save somebody's life. We don't want to do that. We want stabilized plaque. So what happens in the biology of atherosclerosis is you have free radicals, these oxidized lipids, so oxygen-free radicals are hanging around, and then LDL and triglyceride remnants, like we spoke about, Professor, become oxidized, and they traverse the endothelium, and then white blood cells come and eat them up, and I tell the patient, you got a lot of white blood cells eating up a lot of lipids, and then plaque is forming. So the biology is very well known now. We know how plaque forms, but we want to know how to reverse the plaque. So the biology is such that there's a necrotic core and fibrofatty tissue, and that is where this blood test that we use called the pulse score that comes out of California. Dr. Douglas Harrington developed this test, and it shows us what is going on at the risk at the plaque level, at the shoulders, at that soft plaque that's going to burst. We can measure the risk using something called the pulse score. Coronary artery calcification evaluation with CT, coronary CT, too late. Those lesions are calcified. So let's look at this gentleman here, asymptomatic, 78-year-old Middle Eastern male, IT professional. He didn't really have any specific complaints, but he was seen by his primary care doctor. His daughter was concerned. She said, "Dad is tired. He's unmotivated. He's an IT guy." And he said he had a lot of stress in the family. So the doctor said, "Well, let me look. Let me do your lab test." And his lab test showed really not much going on as far as his lipids. They were okay, acceptable. CIMT results showed mild intimal thickening, and the primary care doctor said, "Hey, you're good. You're out of here." Right? The doctor said no, and she took him to an out-of-network cardiologist, and the cardiologist knew about the pulse score. So has anyone ever heard of the pulse score here? Pulse cardiac score. Hopefully you can take this away to your own hometown and use it for your patients, because the pulse score was done and showed an 8.34 times increased risk for acute coronary syndrome. And this has been tested widely across the United States and the world with regard to how effective is the pulse score in detecting risk. It's very significant. So 8.34% expected risk. So he had a 5-year score of 45.9, very elevated. So the daughter sent the patient back to the initial cardiologist, and they did a cath on him, and he had near 100% occlusion of his LAD. It wasn't 100%, and so he had a stent placed. So here's the angiogram. You can see here that pre-stent he almost had 100% blockage of his LAD, and post-stent great flow. So this is a man that had minimal symptoms, comes to your office. I know you see them every day. If you don't do a pulse score, but just look at the lipids that were so elegantly talked about by our colleagues, you may miss the boat entirely. So treatment and follow-up, he was placed on Plavix, aspirin, atorvastatin, and atenolol, and did well over the ensuing So I want to talk about prevention and reversal because as an interventionally trained cardiologist, I know that we can stent anything. Dr. Frazier has taught me that I can put catheters anywhere. But we want to know how can we prevent and reverse that disease. So nutrition, physical activity, smoking cessation, stress management, we know all these things. Compliance is very important, as I talked with our Italian guest here today, right? So compliance is so important about keeping the patient on their medication, which 50% of them stop their medicines. We know that. And then emerging therapies are very important. So the goal of these therapies is to take the unstable lesion to the stable lesion. And that's why we're all here today, because we want to know how can we address the issue of the unstable plaque. What facilitates conversion? Statins, they have a pleiotropic effect, we know. Jardins, olive oil, avocado oil, Mediterranean diet, omega-3 fish oils, vitamin D, ribosine, and glutathione. Those are things that I'm going to talk about today, as well as exercise. So we want to know about what happens in the blood as far as free radicals. Free radicals are attacking the DNA, mutating the DNA, leading towards premature aging, cancer. This is where you got to put your money. Free radicals. It's all about DNA damage because in the mitochondria cannot produce the glutathione and the ATP. All right, glutathione. What is glutathione? People will say, how do you spell that? Glutathione, the master antioxidant. So glutamic acid, cysteine, and glycine. And it's the most abundant antioxidant. But what happens is, after about age 40, what happens to the mitochondria? They get sleepy, and they stop producing the mitochondria. They stop producing the glutathione, and therefore we start to have oxidative stress. And this is why, after about age 40, you wake up and your feet are hurting, right? Or your muscles are hurting. Glutathione production pathway. Let's look at it. You need glutamic acid and cysteine. Cysteine is the major first player in this pathway, and I'm going to show you how you can increase the cysteine to increase the glutathione production. Glutamic acid cysteine complex forms, and then we have the glutathione production. So then, when you have glutathione, you stop oxidative stress. Remember the little cartoon about the oxidative particles causing lipid deposition in the wall, macrophages eating those and creating this necrotic core. We can stop it by increasing the glutathione production. All right, let's see. So this glutathione is rallied in oxidative stress. Let me get to the next slide. All right. So oxidative stress, what is it? People ask me, is that oxygen? My patients will say, isn't oxygen good? I say, yeah, oxygen is good, but after the oxygen is used, you get this free radical, and free radicals are bad everywhere. All over the world, radicals are bad. So free radicals are causing Parkinson's and Alzheimer's, coronary disease, inflammatory bowel disease. You can see a host of diseases here. So then we start thinking, we should have paid attention in biochemistry because it all comes back to biochemistry as far as diseases. All of us are joined together as physicians to take care of the patient, to bring healing to the body, and that's by stopping the oxidative stress. Now, let me get you to the next slide. I'm having a little trouble. All right, there we go. So lipid peroxidation. So oxidation of fats is the most important thing in this process. Free radicals cause those lipids to oxidize. And when lipids oxidize, they traverse the endothelium, and then the plaque formation begins. And it begins very early. We've seen children with plaque in the aorta even around age 5 or 10. So when we're all sitting here, we've eaten our little cheesecake or whatever we had, remember oxidative stress. And think about glutathione peroxidase. We need glutathione to make glutathione peroxidase work, and that's what detoxifies the lipid peroxides. So what can we do? How can we stop this atherosclerosis? There was a clinical trial looking at 636 patients with coronary disease, and they looked at what is the risk of further cardiovascular events based on glutathione peroxidase activity. And they showed that glutathione peroxidase activity was a strong predictor of future cardiovascular events. So that means your cardiovascular patient who's had bypass surgery or stenting, or they come in with unstable angina, or they're just having chest pain and they have stable coronary disease, you need to stop their oxidative stress. So how can we do it? This shows that cardiovascular disease, the events actually decrease with increasing glutathione peroxidase activity. All right, so glutathione, can you take it? Where is it? Give me a bottle. If you take glutathione, it is it's messed up in your gut. You can't absorb glutathione. So this Dr. Herbert Nagasawa, he's 95, I think now. He spent 20 years developing in the Department of Chemistry and Toxicology a ribosine technology where we can take this product and actually absorb cysteine and then produce in the mitochondria glutathione. So he spent 25 years doing that, and the patent was issued in 2013, and this is a great method to enhance delivery of glutathione and ATP levels in cells. So ribosine has, you say, well, are there any published studies? Is this real science? Yes. So we have 23 published studies on glutathione, the initial study, the product characterization, general efficacy studies, and then specific conditions. And you can see down there that cardiovascular was very, very important as a clinical trial, and also wound healing. So a lot of the plastic surgeons love using this product to help wound healing. Shown to protect against oxidative stress by increasing glutathione. Now this is very nice. It was a mouse study showing ribosine, that's D-ribose and cysteine, treating animals with ribosine versus not. And the animals treated with ribosine had no significant plaque formation in the arch of the aorta, whereas the control animals had significant atherosclerosis. So very compelling data, and we feel that the study conclusions from the ApoE negative mouse model study showed that ribosine had similar antioxidant and lipid-lowering effects in different hyperlipidemia mouse models, and it was reducible, and so ribosine was able to protect against cardiovascular disease in the mice, and might be an ideal therapy to increase protection against cardiovascular disease in humans. So I took this to heart, and this physician took it to heart because it was a patient, and I put my patients on the product to increase glutathione production, measured the pulse score on patients, hundreds of patients now in my clinic, and seen 70% reduction of their risk on their pulse score. Amazing data that we have to share with you. Now this was a 52-year-old physician aware of a pre-diabetic status, so cholesterol levels were pretty controlled, hemoglobin A1C was borderline, and these are all our colleagues, right? As we're in medicine, we are under stress, we are increasing our cortisol levels, we're becoming diabetic, and we don't even know because we don't have the time to take care of ourselves, right? So this physician had a 5-year cardiovascular disease risk of normal, 2.38%, and a 10-year risk normal, calculated. But what happened with his lipids? His lipid profile is not so great. It's called normal here, but his LDL was 113, triglyceride 120, but in the standard lab analysis, he was said to be okay. But then we did a pulse score on him, and the pulse score showed significant elevation of his risk. He had a pulse score in the 7.49, so he had a very high risk of having an acute coronary event. And I hope you all are sitting out there thinking that you each need a pulse score done on you, because we can save lives like this. So the patient was put on therapy, including ribosine therapy, and follow-up pulse. And I usually do these pulse scores at 3 and 6 months to reevaluate the patient on therapy. His pulse score went from 8.7 to 2.2, and I have seen this over and over and over again. And patients feel the glutathione actually, they feel their ATP improving, but we can show them on the pulse score and actually vascular ultrasound that their plaque is diminishing. He's of course doing lifestyle modification, but adding the ribosine is the key. So I only had 10 minutes, and I think I got it. So questions you can ask later, but we want to continue onward here. And I think, do you want to introduce the next
Well, thank you. Thank you, Annie.